The meeting is on. Wonderful. So exactly on time. Thank you very much. Most welcome to everyone who has called in to this webinar on the multisectoral approach towards mental health and psychosocial support in humanitarian settings, needs, achievements, and gaps. I'm very happy to see that there are quite a lot of participants, even if I think we came a little bit late announcing this seminar. But sometimes that's smart, because then it stands high on the horizon. I'm Renette van der Waals. I'm a coordinator on the MHPSS in the Netherlands Foreign Policy, in the Netherlands Ministry of Foreign Affairs. Our ministry in the Netherlands has been involved in mental health and psychosocial support in humanitarian settings for a number of years now, trying to raise the understanding and the importance of the subject, in order to enable the work that many of you are doing, and especially the esteemed guests that we have in our panel. Today's webinar is initiated by UNFPA, and I really would like to thank especially Henya Dakak for that, because we think it's very important to grasp the opportunity at the ECOSOC Humanitarian Affairs segment to indeed address the issue of MHPSS in humanitarian settings. Today we have a 1.5 hour session, which always seems long and which always goes by far too fast. I'll be trying to keep track of time and not to talk too much, but I will briefly introduce, say, a few introductory words before moving to our panel, who are people that are working in the field and that are working, coordinating, being co-chair of MHPSS technical working groups in 5 crisis settings. And that is what we found very important for the session today. Departing from the field and from the reality of from day to day trying to bolster attention for MHPS needs, with mental health and psychosocial needs, because having that attention means that then we can enable your work because there's more attention for that. In the field, you're also working on the actual integration of MHPSS in crisis response. You're adapting existing tools and materials to local humanitarian contexts. You're applying guidelines and principles to ensure that quality is ensured, and that context is taken into account of working in your specific circumstances. And you're feeding back your experience and findings, again, to those at headquarter level, at global level, who are further developing tools and materials. So that's the core, the feedback from the field today. There will be a few outlines given by, let's say, representatives of headquarters who work more at the global level on guidelines and tools available to support the discussion. And let me with that introduce our panelists from what I call the field. We have with us Deborah Magdalena, who's the Maiduguri MHPSS Technical Working Group Coordinator, working in Nigeria, therefore, and working with IOM. And welcome, Deborah. We have Ibrahim Abu Khalil, who's in Yemen working as the SANA MHPSS Technical Working Group Coordinator and who's working with WHO. We have Maya Tucker, who's MHPSS Technical Working Group Coordinator in Myanmar and working with UNFPA. Welcome, Maya. We have Nikos Kionakis, who's the Athens MHPSS Coordinator, Technical Working Group Coordinator, and working with the Babel Migrants Center in Greece. We have Sanem Ozen, who's the Cox's Bazar MHPSS Technical Working Group Coordinator, and who's working with UNHCR in Bangladesh. We have Sandra Katz, who works with the Netherlands Enterprise Agency, which is the agency that that monitors and that works on the Dutch search support, MHPSS search mechanism. And we have Dr. Fahmi Hanna, who's working with WHO and who's also importantly co-chair of the IASC MHPSS Reference Group, as is Carmen Valle, who is also co-chair of the same group and who works with the IFRC Psychosocial Center. So an eminent panel with experience from different levels. Very briefly, we will start with a question to all panelists. Then there will be a couple of explanations on tools such as the search mechanism and work by the Red Cross, Red Crescent movement on integration of MHPSS in crisis response. And then we will have a second round of questions to the panelists. And meantime, I can see already quite a lot of chatting ongoing. Please do use the chat to ask possible questions that we will bring to the panel at the end of this session in order to take along also ideas and questions from our audience. Please be aware, few technical issues. The session will be recorded and so that we can share it afterwards. We are, please feel free to ask questions through the chat and follow the chat as well. Follow especially the speakers, but follow the chat as well because guidance materials and suggestions will be shared through the chat. I've been mentioning a lot of issues about technical working groups, but as maybe not everyone in the audience knows what MHPSS technical working groups are and what they are doing, we will start with a very brief introduction on that subject. And therefore, Fahmi, please, the floor is yours.
Thank you so much. Thank you for being here and for moderating this session and for all the effective advocacy from the Ministry of Foreign Affairs of the Netherlands for MHPSS and specifically to you. I want also to start by thanking Hania. Without her advocacy, I don't think this event would have been organized. Hania is also planning for a global advocacy campaign for MHPSS titled Time to Heal by UNFPA that I hope all of us will stay tuned for, which will be launched very soon. I hope you all can see my slides.
Yes.
Perfect. Thank you. Colleagues, this is the structure of the Interagency Standing Committee Mental Health and Psychosocial Support Reference Group, which is the structure within the humanitarian system which supports the coordination of this cross-cutting area of work, mental health and psychosocial support in emergencies. In fact, the term was coined with the release of the MHPSS ISC guidelines back in 2007, and the ISC Reference Group is currently co-chaired by WHO and the IFRC, and this position of co-chair is a rotatory position. Formerly, it was co-chaired by agencies such as World Vision and UNICEF, and at some point WHO and IFRC will hand it over to another agency as well. It is composed of 60 members. Membership is by agencies, and it represent all United Nations agencies, international NGOs, Red Cross and Red Crescent societies who are active in mental health and psychosocial support. The reference group exists to set norms and standards and practical tools for mental health and psychosocial support, to connect with global coordination structures in the humanitarian system and mainstream mental health and psychosocial support. So day to day, Carmen and I will be, and other members of the group will be working with global coordination clusters, with IC result groups, with different coordination bodies within the humanitarian system, with donor groups, with sphere colleagues, with Child Protection Alliance, with all coordination structure to make sure that mental health and psychosocial support is integrated. And most importantly, a key role, The IC reference group do exist because within the humanitarian system, it is the structure responsible for supporting the country-level mental health and psychosocial support technical working group. Currently, we have 53 countries in humanitarian settings which have mental health and psychosocial support technical working group, a huge number. It's important to note that this technical working group has increased significantly during COVID-19. In fact, it was until March last year only 23 countries, more than twofold increase to reach 53 countries, which I think showing the importance and recognition of this area of work in humanitarian settings. In good humanitarian practice, mental health and psychosocial support is a cross-cutting area, and it is recognized as a cross-cutting area by IASC principles. In good humanitarian practice, you will see mental health and psychosocial support actors which are integrating mental health and general health care, for example, in health sector, or mainstreaming mental health and psychosocial aspects within gender-based violence response, or doing school mental health promotion within education sector. But the place where all these MHPSS practitioners from different sectors and clusters come together is the mental health and psychosocial support technical working group, a place where MHPSS actors from different sectors and clusters work together to plan, to implement, and to coordinate MHPSS activities. The IASC reference group support country-level MHPSS technical working groups through regular teleconference, specifically also at the onset of a new emergency, country support missions, annual retreats, practical tools, and setting the norms and standards for these groups, and also the inter-agency support surge that my colleague Sandra will be presenting on later, where we collaborate with the Dutch surge support. I'm not going to discuss the tools, but my colleague Carmen will be sharing a link to access all our tools, specifically the tools developed during the COVID-19 context. But a common issue around all these tools is that they are available in numerous languages. Some of them are available in more than 100 languages. Many of them are available in more than 25 language plus. And these tools are used extensively and adapted by the colleagues you will hear from humanitarian settings. Thank you so much, Renat.
Thank you, Fahmi. I was just starting to think you're always such a good and enthusiastic briefer. I think that's a very good kickoff of today's meeting, but let's indeed now quickly move to those of you who are working actually on coordination in the field and promotion of integration of MHPSS in humanitarian work. And you're working in very challenging situations. And I would like to start with you, Deborah, because you're working in Maiduguri in Nigeria. You have worked hard to ensure MHPSS response to COVID in a region which is affected also by high levels of insecurity. And what did you do to manage that? What enabled your work? How did you manage to maybe make use of the existence of the technical working group as a co-chair of that group to ensure that MHPSS was integrated in the COVID response? Thank you.
Thank you so much, Renat. Just to check on my audio, if you can hear me well. Yes. Okay, great. So thank you so much for the questions. Yeah, I think if we are talking about the coordination role and and how important is the working group through our responses, I think what we can share from the Northeast Nigeria, we have the advantage of having a well-structured coordination platform as a MHPSS working group, and then we have a constant communication ahead before the COVID-19 pandemic. And also we did a lot of mainstreaming of mental health and psychosocial support. We did also the integration, as what Dr. Fahmi already mentioned about the role of coordination with other sectors. I think it really helps before the pandemic happens. We didn't say that, okay, we did it very well and it's very excellent before, because we never know what happened at the beginning of the COVID-19. But our communication with the partners and stakeholders, and also understanding our role as the humanitarian actors within the state government, that we are supporting the government of Nigeria. We're working closely with the State Ministry of Health. We know our capacity. And I think the mapping is really helpful. So we know whose partners having the capacity and also whose partners doing in which locations. The last mapping that we conducted, we have 49 partners, and it comprises of civil society organization, national NGOs, international NGOs, UN agency, and also RCRC movement, and also of course with the government institutions. So I think that's really helps. And also the collaborations. We know that this is a very key within the COVID-19 situation, that we need to work with the local partners. We need to work with the national actors where there is no access to the IDP camps inside of the Northeast Nigeria. We know that the one that can work doing even implementing the MHPSS responses is actually the community, the national actors who can go access within their area. So I think this is the really key component that we really I can say that we are grateful for having all this coordination and also collaboration with all partners. And I can say that also the government is very, very responsive. Over to you, Rana. Thank you.
Thank you so much for giving us an insight. And I think one of the things you illustrate clearly is how important preparedness is, also preparedness to provide MHPSS in forthcoming emergencies, and as well as the good role vis-a-vis authorities, and the importance of working with local partners. I think that will come back throughout the session. Nikos, may I move to you? And you are also working in a very challenging context in Greece, maybe very different, but needs are enormous. And ensuring that mental health and psychosocial needs are taken along and not forgotten in the response is quite hard. So how, as co-chair, do you in a way use also the technical working group to ensure that across clusters and sectors, mental health needs are recognized and addressed, and that you work together, and that the potential, excuse me, of MHPSS is recognized? Over to you.
Yeah, thank you very much for this. I would like to show how we work, saying that the last days we, as a MHPSS working group, we wrote down and we sent a letter to the Deputy Minister of Health that is appointed for mental health, because in Greece we have a Deputy Minister who is appointed for mental health, in which we present our considerations about the challenges people meet concerning their mental health, and our proposals about this. And the interesting thing for me is that we adopted, in order to structure this letter, the pyramid of IASC. I mean that what we did was to refer to the considerations and to the proposals, having in mind this pyramid. To put it another way, we also wrote another letter accompanying the first one, in which we were presenting the pyramid and how it functions, so that our considerations and our proposals could be understood and contextualized. And from the other hand, we also asked for a meeting with the Deputy Minister in order to discuss all this. And this in the view of a working group that works in the Ministry of Health, in order to make the new mental health plan for the country, in which we want our vision to be endorsed if it is possible. And this means that we try to show how important it is, not only mental health, but which direction our intervention takes. And this is something that has been used in order to also to mobilize the humanitarian actors to see how important is mental health, because we have the same problem with the humanitarian actors, for which, for many of them, mental health is something like the poor relative. They do not pay much attention, and we need to show them how important it is, not as a specialized intervention, but as a multisectoral, multi-layered actions plan and application, and that requires a shift paradigm, let's say. I think.
Thank you.
how it works. Thank you very much.
Thank you very much, Nikos. And I think what you show is how important it is to join forces and to join voices, and how also internationally agreed guidelines and principles like the pyramid approach help in that, in even prioritizing. And indeed, work with humanitarian actors, with governments is very important. I think the ongoing plea for taking MHPSS seriously from the very start is a message that we keep on promoting, I think, also through sessions like these. So thank you for that. I propose we now move to Myanmar. And Maya, I think we hear so much, we hear the extent of the needs, and that can sometimes seem overwhelming. There's so much to address, and sometimes in very difficult circumstances to work on that with scarce local and international capacities. And I know that you've worked already since long on integrating MHPSS into several responses. What is your experience? How do you manage through coordination to show that MHPSS really is a priority from the very beginning? And what role can coordination play in passing this message on? Thank you.
Thank you so much for that question. So in Myanmar, the MHPSS Technical Working Group coordinates across sectors, including health and education and emergencies. But it is under the protection sector, which is really a facilitating factor for close coordination with protection actors to ensure integration and a complementary response, as many protection activities and services serve as an entry point for MHPSS interventions. In Myanmar, there is limited availability of mental health service providers, so it's crucial for cross-sectoral coordination and capacity building, particularly of child protection and gender-based violence actors and case managers, in order to have a wider coverage of MHPSS support. Through cross-sectoral coordination, resource sharing, mapping of referral services, and training, we're able to strengthen MHPSS capacity of frontline workers to enhance psychosocial support for crisis-affected populations and the identification of people in need to ensure their safeguarding, well-being, and referral to mental health services. We're working very hard to ensure that we have strengthened cross-sectoral referral mapping at a local level, and this is a critical component of comprehensive protection. For example, a gender-based violence survivor is often in need of MHPSS services. Cross-sectoral coordination is critical because the needs of people are cross-sectoral. Coordination and meaningful collaboration strengthens the ability to address the range of needs that people face in a humanitarian emergency. In Myanmar, the protection sector mainstreams MHPSS as an integrated aspect of humanitarian and protection services. The MHPSS Technical Working Group has developed many tools and resources to support all humanitarian actors. One example of the impact of this integrated approach was in the onset of COVID-19, when field activities were restricted to essential services. The Technical Working Group developed COVID-19 MHPSS supportive material that was mainstreamed into the distribution of hygiene kits, food distributions, and at health and quarantine centers. We had to adopt our approach and ensure that MHPSS still reached people in times of lockdown and quarantine. The MHPSS Technical Working Group coordinated with many sector technical working groups and local partners to distribute over 300,000 MHPSS supportive materials related to COVID-19. And these resources include 6 local language versions of picture-based booklets addressing coping with crisis for parents and adults, as well as a coloring book for children with key messages on health, hygiene, and coping with COVID-19. These efforts were made through the already established coordination linkages between the technical working groups. The role that coordination can play must focus on the importance of the inclusion of local organizations and professionals in the group and in our processes. We strive in Myanmar to act as a collective technical input and support sector. Our biggest achievement and challenge has been getting local participation and ownership, as this is critical within complex and prolonged emergencies, particularly when access is an issue. Thank you.
Thank you so much. That's really impressive. The examples that you meant, what you managed to do, but also your whole message. I think a couple of things that I clearly retained is the cross-sectoral coordination is so important because on the one hand, it helps you get wider coverage and resource sharing, again, joining forces, but on the other hand, also because the needs are cross-sectoral. And I think those two elements are very important arguments for this coordination. But I was also impressed by what you said about local language materials and increasing local participation and ownership, even though that is and remains difficult. I would like to move to Sanem, and who's working in Bangladesh. Different circumstances, different context, same region. What is your contribution? Sorry, that's also interesting, but what's your experience with the contribution that the technical working group can make to the work that you're trying to do?
One of the key highlights of Bangladesh context will be, as you note, emergency within an emergency. This is a context that continuously, whether it's weather, whether it's COVID, whether it's other challenges that the region poses, it is quite a lot of high emergency within an emergency. So basically, with that being said, I would like to touch what Bami was said about collective collaboration and MHPSS technical working groups being a place for sectors and actors to come together to share the burden, which is an important aspect of MHPSS technical working group. So we work very closely as Maya and as other colleagues as well, cross-sectorially with other sectors to improve and strengthen the quality of MHPSS services. One of the examples that I can give, this is a context where specialized services do not exist. Within the region, there's only one psychiatrist as of now, which you can imagine for both host and refugee community, it poses huge challenges. So one of the initiatives with IOM, WHO, and the Ministry of Health is rollout of an MHGAP training, which is a training that supports the identification and management of mental health patients, which is quite important in a context with lack of specialists and lack of inpatient care. The other one that I would like to note also, going back to what our colleague have stated, is cross-sectorial efforts. And this doesn't only strengthen the MHPSS response, widen the coverage of it, but also it helps in sharing the burden of it, as noted. We have a cross-action plan with GBV sector, and this does not only cover capacity building for GBV, but it also covers capacity building for MHPSS actors. Because when somebody is faced with abuse, whether it's a child or a female or a male, it is important to keep well-being in mind as you offer services. And this could be distribution services or case management services or any other related services. And on the last note that I would like to say is self-care. So we as MHPSS working group in Bangladesh recognize the importance of self-care and staff care. And we do take an initiative to widen the scope of this to all sectors because we think there is no support that is possible without our self-care. So thank you so much, Renee.
Thank you very much, Sanem. And I think you're also touching on a number of important issues. Again, sharing the burden in the working group, but also working on ensuring quality, joining forces when in training. And I think the issue of staff well-being and first responders well-being is very important. And I think it's also an issue that has gained more attention over the past year and a half with all the COVID responders. So it's better understood now. Ibrahim, may I come to you? And the largest humanitarian crisis, I think, in the world in Yemen, and definitely a place also with emergencies within emergencies or compounding crisis, but also very good examples of MHPSS in the crisis response. and you are also co-chair of the Yemen Technical Working Group. How do you manage to ensure at least a certain level of MHPSS in the overall response? Does the Technical Working Group help you in achieving that?
Thank you, Renee, for this relevant question. And thank you, colleagues, and good morning, everyone. And I'm really glad to see the number of people that are participating from Yemen. It shows how people are interested, actually, and how much they are involved and dedicated into improving that. Unfortunately, one of the key things that Yemen context teaches us is that needs have no sector, if no one party can do any proper response or prevention or address the needs and the gaps and so on. And it has to be, I mean, you want to call it multisectoral, you want to call it, I mean, multidisciplinary and so on. It has to involve every single party that is really working on the ground in order to address actually the needs of the people and to improve the access and so on. But how can we do that? And this is I mean, a $1 million question. I think relatively, and learning from experience, and this is something I think Fahmi once said back I mean, a few months or a few years back, it depends on the chemistry of people, you know, the chemistry, not of the person, of the individuals, but the relationship between people. And I think one of the key things, and colleagues here, I'm echoing just what I've heard so far and what's really happening, and they can, of course, tackle this and comment on this, is that it depends on how you do that, because it's either like a good working relationship or it's really not working at all. And this is what's really happening. And unfortunately, this is what's really affecting us, because I mean, the efforts of the technical working group in Yemen is fluctuating. Sometimes we're not allowed, you know, to hold meetings, and now we're in discussion in order to go back and do the coordination. And we try as much as we can. And we have a lot of involved. I'm not going to name them now, and some of them are here on the call, and I truly appreciate their participation. And without their involvement, without their dedication and commitment, I mean, nothing in terms of coordination could be implemented and could be there in order to improve the access of people who are in need to these services. This is from my end. In case you have any other comments or questions, I'm glad to answer it in the chat box. Thank you, Renee.
Thank you very much, Ibrahim. And I think fair enough to mention also that, of course, whether a technical working group, as any kind of working group, can be effective or not very much depends on circumstance. And I think it's good to really look into what makes a working group work well and what can be an obstacle. And that's why I also, what appeals to me very much is that there is the regular call among working group coordinators worldwide, so that you can share experience, even if contexts may be very, very different. So we heard a lot about the importance of coordination at the national level. At the same time, there's a lot of work ongoing at the global level to support the work being done by specific technical working groups and all their members, by coordinators. And one of the examples of such globally prepared support is the work being done by the Red Cross, Red Crescent movement on the basis of a resolution of the end of 2019. And now Carmen Valle, as not so much as a co-chair, but as working with the IFRC Psychosocial Center, will give us a brief introduction or explanation about that resolution and the roadmap that was developed to implement that resolution. Over to you, Carmen.
Thank you so much, Renee, and colleagues, for your wonderful presentation so far. I'm going to just give you a little bit of an update on the policy and resolution and the roadmap, and then I will pass the the links in the chat afterwards, because I'm not very good at multitasking. So I'll talk for now, and I'll share the links of everything I'm talking about later. But indeed, I think what was mentioned by colleagues today it touches very strongly on that need to localize and to coordinate at country level, and to make each intervention ours in terms of the country. And in that sense, the Red Cross and Red Crescent movement is in a very unique place, because we do our work through 196 national societies. Every country almost has a Red Cross. So being our work so connected to alleviating human suffering, and being mental health and psychosocial support an essential part of alleviating that suffering, there was a moment in 2019 when the movement as a whole saw the need to have a little bit more of a how to address mental health and psychosocial support in the entire movement. So something that would go across all of the structures of the Red Cross Red Crescent movement. So in 2019, in December 2019, we made what I think is a historical commitment to mental health and psychosocial support by adopting the policy, the joint movement policy on mental health and psychosocial support. And together with it, that's an internal policy that tells the movement and the different national societies, IFRC, ICRC, how to do more quality, more targeted and more specific mental health and psychosocial support. But at the same time, we have what I also think is an incredible opportunity to sign together with 196 states the resolution, which is a broader document addressing the needs of countries, stakeholders, and national societies to come together for a much stronger recognition of the needs of persons in humanitarian settings in mental health and psychosocial support. So bringing this awareness with a resolution, and then the policy helping us specifically in the movement on how to do it. In that regard, that was the 2019. Yes, this is a great commitment from all of us. Now, how? So in 2020, the movement developed a roadmap, which is a series of steps on how are we going to do this? What are the activities, the commitments, especially what are the outputs and outcomes that we want to measure in 2023? We're getting there slowly but surely. And that roadmap is both the policy, the resolution, and the roadmap have been very strongly inputted by the national societies. Again, going back to that need to work at country level. So what we continue to do during 2021 is to provide ways for the national societies to continue to be very strongly connected to the implementation of the roadmap as a way to achieve the policy. So we are developing webinars in multiple languages where we invite the national societies from different regions to understand better what is the policy, the resolution, the roadmap. We have created a number of working groups that connect with each of the 6 priority areas of the policy. And we are really encouraging national societies to join these work groups. So the decisions that I made along the way come from country level very strongly. And then together we're doing podcasts and videos and articles and a lot of opportunities to think together, and not so much to create this structure where we create something that then national societies feel they have to do without really understanding what is their role. So it's very bottom up and top down and all together. And I think it's really going to mean massive growth on the Red Cross Red Crescent movement, mental health and psychosocial support implementations globally. For us, that is really exciting because it means pretty much everywhere in the world. So that's what we are excited about these days. Over to you, Renee.
Thank you so much, Carmen. And indeed, it's exciting also to look on and to see examples of national societies really, for example, in the COVID response, taking this on and working on it. And I can say that in the Netherlands, in our promoting of these subjects, we also often use those kinds of examples to show the possibilities and the power actually of working like this. I would like to move to Sandra Katz of the Netherlands Enterprise Agency, which is managing the search mechanism. And for a brief explanation, about that mechanism. Sandra, over to you.
Thanks, Renette. Yeah, happy to hear all these local stories, because that is what everything is about. And what we would like to add with this search mechanism is actually to support you guys in the field with an expert, which we recruit also from the MHPSS community. Basically, the search mechanism was established after the conference that we had in the Netherlands, and it is basically to support the advocacy of our Minister Kaag to put MHPSS on the international agenda in the humanitarian sector. So we are very concrete in that sense, something else than just talking. We just have an expert in the field. And how do the experts get there? Basically through a request from the field. So we have this network, and we work together with the IASC Reference Group, which is most important, because we as an organization are not particularly knowledgeable on MHPSS, but we do have the structure how to get someone in the field. So we basically provide a database in which experts can subscribe, and I put the link in the chat somewhere. Well, before the other messages that have gone over it later on. So if you're interested as an expert, you can subscribe. And I would like to emphasize that the time in the field, we have limited it to 3 months. And we do that on purpose because we don't want long-term experts in the field. This is basically up to you as an organization to take care of that. But we can give a boost for a maximum of 3 months to getting MHPSS on the agenda, or to give it a boost in a specific expertise. Because you can, of course, put the expertise that is needed and meets the local needs in the TOR that you send through basically the headquarters of the organization, or straight to us, but then we also go back to your headquarters most of the time, because what we want is to have the experts grounded in the field in your security system. That is one of our main efforts that we need to establish. The consultants, because they are consultants, they get a consultant contract. And this is a bit of a misunderstanding, because in the humanitarian sector, many of the experts are actually deployed by the agency. We don't do that because it's a very short-term contract that we have. Basically what we do, we select, we make a first selection after we have posted the request into the standby partnership network. And then, of course, in our database. And then we look very nicely towards Carmen and Fami to help us with the first selection. And then, of course, we send the first selection that we made to the country, and the country team actually made a final decision. Because, of course, you have to work with them. And that is why it's so important to connect to the local team. Furthermore, we organize an insurance for the expert, because sometimes the countries are, so to say, red. So you're not allowed to go in as a tourist or whatever. And then you cannot get an insurance by yourself. So we will organize that. Tickets have to be organized in consent, because we need to know if there's a visa and all these administrative things. But we try to do it very quickly as we can, depending on the procedures in country. And then someone can stay there for about 3 months. And we, of course, support the expert as well by coaching or by, basically psychosocial support, because sometimes these people hear and see a lot as well. So we do have our duty of care and take care of the experts. I think I leave it here now because of the time. Renette, going back to you.
Thank you very much, Sandra. And I thank you for explaining the mechanism. And I would like to just say that there are a couple of examples where first an expert was sent for 3 months by this mechanism, and where after that the hosting organization actually created a longer term function for MHPSS. And I think that's a very good example. We've really tried to set up this system, this mechanism in such a way that it links in with the international humanitarian system as good as possible, so that it supports and supports that work and is continued by those counterparts. And I'd like to move to Ibrahim again. We also wanted to discuss gaps during this meeting. It's in the title, and that's for a reason. The idea behind this search mechanism is that it helps reduce gaps at the short term and urgent emergency gaps, let's say. Did it work like that? I think there was an expert who was based in Aden. Did it work like that? And would you have advice to those working at the global level, at HQ level, so to us, on this mechanism and maybe other ways to help alleviate gaps?
Yeah, thank you, Renate. And I think this is a good opportunity also to say that there are no words actually to describe and to thank actually this mechanism and Sandra and the colleagues also for their support, because I don't know how to say it, but it helps a lot. It addresses the gap in that sense, and it's easy to work with, and it's functional, and it really helped us a lot in Aden, because the technical capacity is really low, and the coordination was really not there at all. We launched the technical working group. We could not sustain it because we could not have access into Aden and so on. And then when we started the discussion about like having somebody, it helped us a lot to have a person actually who's dedicated to the coordination mechanism, and helped a lot in like rolling out some trainings, involving the ministries, Ministry of Health, Ministry of Social Affairs, Ministry of Education, the various clusters, subgroups, and so on. And it helped on that level. Now, if we want to talk and truly again, and I think this initiative should be repeated, should be extended in terms of time frame, because as you know, one of the key challenges that we're facing all is that MHPSS is not on the top list of priorities for the funding, any funding around the world. And this is something we constantly face, and it's a challenging thing, and it's constant, and I hope it will change in that sense. The other thing is related to what I want. It's an internal thing, and if Sandra will allow me to talk about this. I think the 3 months period, however, they address the gap and so on, but it's really short. It took us a month and a half in order to bring that person into the country, because of like all the logistical aspects, all the visa processing, all that whole thing. And by the time he arrived and he wanted to contact people and to sit with them, it took him 2 to 3 weeks in order to get the mobilization and so on. And this is one of the things, is that actually if there is a mechanism that could be extended a little bit in time. The people are excellent actually who are on the roster who could come, because the person who was really there, without like naming people, he did a great job, I mean, within this opportunity. And I hope we can have more and more initiative, more people deployed in order to address such gaps and work on that, and maybe have it for a longer time. I hope that addressed your question, Renate, and answered it.
Yes, and you are challenging me, because I'm also representing the country which is at the moment providing that support. Thank you for your remarks. I think one of the things I heard and that I recognize is that coordination takes time, coordinating takes time, liaising with government, with ministries involved, with other organizations. And so, and having expertise in how to do that and how to present MHPSS also to those who may know a bit less about it is important, which is what this search mechanism responds to. I have also heard your call for more than 3 months. I think this is always the difficulty with scarce means and how can you divide your means, but we'll continue that discussion. And I will also call on people who are in this call, in the audience, if you're interested in joining the mechanism and helping to support it and develop it further, please do contact any of us. Maya. Capacity in a quantitative way, but also in a qualitative way, expertise, sense of skills and expertise. It is an issue. It was raised before. So the search mechanism tries to address the short-term need for extra hands, extra minds and expertise to help coordinate MHPSS. The briefing of Carmen on the RCRC roadmap shows also how on the longer term you can work in increasing capacity worldwide by basic training of first responders. You were referring to training of basic psychosocial skills among local responders. Can you share what is needed to enable this? So what helps you, for example, in undertaking such an initiative?
Yeah, thank you. So with the onset of COVID-19, there was a great need to prepare first responders and essential workers with basic psychosocial skills to support persons experiencing distress related to the crisis, as well as to strengthen first responders' awareness of self-care and their own well-being. The Interagency Standing Committee developed the resource Basic Psychosocial Skills, a guide for COVID-19 responders, and the MHPSS Technical Working Group translated this resource into 5 local Myanmar languages. And training was provided to first responders who were providing a range of protection and health services. Additionally, we combine this training with an overview of referral support to safely link persons experiencing distress to MHPSS services and training on local referral mapping tools that have been developed by the Technical Working Group. Currently, we're in the process of adapting the 5 language versions of this resource into offline audio and video training because of the challenges of internet access in remote locations in Myanmar. The MHPSS Technical Working Group in Myanmar recognizes that capacity building must strengthen the ability of first responders who are often supporting communities that speak different dialects from the main language spoken in that country. So in order to truly build capacity of first responders who are also from these communities, the resources that have been developed at the global level must be translated and adapted to the local context with the support and input of local partners. Additionally, it's important to mention that MHPSS capacity building training in self-care and staff care for child protection and gender-based violence actors and case managers has played a critical role in highlighting the fact that self-care and staff care is a best practice and directly relates to the quality of services that are being provided. This is why MHPSS Technical Working Group members provide online staff care and self-care courses for GBV and child protection frontline providers. Thank you.
Thank you so much. And I think your point about involving local actors in adapting, translating and adapting materials is so important, as it is in any action actually. And your point about self-care and staff care as a best practice, which is also probably an argument that can be used with first responders that work in other sectors, because they also need their self-care, which makes more responsiveness to MHPSS needs more understandable, maybe. Sanem, may I move to you? I have seen very impressive examples of people living at the moment in Cox's Bazar and who are playing, who are people with lived experience and who are now playing a role as first responders on psychosocial needs among peers. Can you share experience on that, please?
Thank you, Renee. So building on pretty much what Maya was talking about, local adaptation of tools. to actually having implementation by refugees and by communities themselves. Basically, with the highlight of pandemic, as you know, many contexts had zero access, if any, maybe very limited access to the grounds. So what we relied on literally was the trained capacity in the field, in the camps itself, in the communities itself, even in host communities. So basically, as technical working group in coordination with IOM, we focus on widening the scope of paracounselor modality. And this goes to one of the questions that were asked by the participants. Monica, thank you, for sustainability of care in all layers. You know, by training refugees or communities in responses like paracounselor modalities, like volunteers, utilizing them to widen the scope of MHPSS and to provide information to their own peers, to their own communities, helps in increasing access, decreasing stigma in more sustainable and culturally appropriate manners. And we have to recognize, as Carmen put it, is that making interventions our own, you know, we have to acknowledge that they are the present and the future of their own communities. So it's very important to build and design activities with refugees, with communities themselves. The last point I would like to touch on this is the importance of proper training and supervision during this launch. So if you are looking to launch community-based MHPSS interventions, it's important, it's vital to consider supervision, vital to consider proper training curriculums that so that the response could be more sustainable even when we are not there. So thank you so much. Over to you, Renee.
And thank you, Sanem, both for addressing the issue of stigma, which I think is indeed an issue to be discussed as well, and on which working with local communities and with peer support is part of an answer. As well, your point about proper training and supervision, training curriculum supervision, very important, quality control, let's say, especially because MHPSS gets more and more attention, which means that also actors come in that don't have a lot of experience. And we all know that we have to work with the principle of do no harm. And it's easy to say, but it's more difficult to ensure that. Nikos, in Greece, you have worked with reference group materials and other guidance materials available. And I know that you have also very much contributed to the further development of those materials. Could you tell about how you worked with those materials and how they help you and where there are possible gaps in them?
Yeah, thank you very much. I would say that we started in 2015-16 by translating and using the PFA, psychological first aid material, and we still use it very much. And in 2019, we translated and published in Greek the guidelines by IASC on MHPSS in emergencies. And later on with the COVID, we translated and published in Greek all the materials that were published by IASC, and we use them in improving the skills of professionals who work in the field, either with refugees, but also with professionals who now work under a project funded by the Greek Ministry of Health, to meet the needs of the population that came out with the COVID-19. And so we had the chance to add, let's say, our forces, our know-how and so on, with the ones that come from the local staff and the local organizations and institutions. And what we have also tried, and we did with the last publication on the elderly, Living with the Times, was to engage in this publication the Greek Federation of Organizations working with mental health and psychosocial rehabilitation. And for us, it was very important because little by little we start to, mobilize those who work with the Greek population mainly, not only with refugees.
Thank you so much, Nikos. And you touch on something, the work that's being done in humanitarian settings by the local international organizations is also feeding back into work being done at home, depending on the set. I can tell this for the Netherlands. We are very much using also examples, international examples, to feed into what's being done within the Netherlands, especially in COVID times, and to show that that is very valuable experience and that those are valuable materials. Thus, for example, I've been promoting a lot the My Hero Is You children's book on COVID, and that shows the cross purposes of all that we are doing. So thank you for sharing that also. Deborah, we started with you, and now I come to you with a final, before the Q&A session, but with a final question. You're working in a very volatile situation, as many of the others, but possibly you work also in a situation where humanitarian actors are maybe, this is a supposition on my side, but a bit less influentially present than in certain other humanitarian settings. And as Netherlands last year, we undertook an initiative and efforts to increase international recognition of the fact that ensuring access to MHPSS is a responsibility and a human and intelligent thing to do, not only in humanitarian settings and by humanitarian actors, but also as part of development, as part of conflict prevention, peace building. And because mental health and psychosocial needs are enormous, and the response really has to be carried by all those actors, by all those, if we want to start reducing gaps. Sorry, that was a long introduction to the question, but do you have comments on this or recommendations on this even broader approach towards MHPSS?
Thank you so much, Finance, for the questions. Yeah. So basically what I can share, we all agree that it's back to the keywords that we wanted or we are aiming for sustainability. Within our responses, especially on the mental health and psychosocial supports. But this is also the reality on ground that I mentioned in the beginning with my statement that we are focusing on also in preparedness, but also at times we are only or maybe even like preoccupied by the focus on the current situations, which is the emergency response with the crisis that's just happening. We tend to forget that this is not a one-time activity that we have to do. It's like a really longer period. We have to ensure that our responses in all cycles, including on the development and also in the transition, so all these words. So I think there's also a fact Ibrahim mentioned about the funding issue. So we also face the reality about the donor fatigue, that they are not only want to give the money to the emergency response, but also through the development. Then also there's another issue with the high turnover of the international expertise, that how can we ensure our program can be sustained if we are only relying on the international expertise, that we are not actually increasing the capacity of the national actors who will be like staying here for more than us. So I think I can share like two initiatives that we have in the Northeast Nigeria. So first is the initiative from actually the global or the region of the Lake Chad Basin. Because the context in here, the insurgency of the Boko Haram is not only affected Nigeria, but it's also affected the other part of our neighboring country, which is Chad, which is Cameroon, which is Niger. So there's like an initiative within our region that we have an operational strategy to improve our responses, then it's also included the mental health and psychosocial support responses within the region. So we're building our capacity not only for the Northeast Nigeria, not only for Nigeria, but also with Chad, with Cameroon and Niger. And I think the second initiative, what I can say in related with the peace building and also development. So an example of IOM, what IOM is currently doing is actually engaging with the University of Maiduguri, which is one of the university located at the affected state, which is the Borno state. So we're implementing and rolling out a postgraduate program for professional master of counseling and conflict transformations. So we want to make sure that this individuals who's been working in this humanitarian crisis can have like a certificate as a professional dealing with the counseling and also conflict transformations. So this is really supported by our donors, especially, and also with the organization and also with the University of Maiduguri. So I think this is just two examples of initiative that I think can be like really useful also for others. Thank you so much, Renil. Back to you.
And thank you for that reply. And I think that with the recently endorsed updated Mental Health Action Plan 2013-2030, which now has more relevant materials in it for crisis situations, but which on the other hand, of course, also deals with what you call it, non-crisis situations. I think that is a tool which crosses over across the nexus, if we use that word. But the MHPSS preparedness indicator in that updated mental health action plan also makes that plan more relevant to the work in the humanitarian sector. I know that there a lot of discussions have been going on in the chat, or at least exchanges, and we've received quite a number of interesting questions. And I would move to it. I just have to scroll on my phone for that, but there is a question on, I'm going to read it aloud. Working across sectors implies working across agencies. But there's also a lot of inward looking inside agencies, which is hampering cross-sectoral cooperation. And there's anxiety about giving cases away to others. I think that's an interesting remark, yeah. So the question is, what can be done to have all agencies working for the greater good, for the higher level, agency overriding level? And the second question is, in many countries, there is also a private sector operating in parallel with humanitarian actors. And should they be part of cross-sectoral cooperation? And I think, I think that Dr. Fahmy already knew that I was going to ask him to respond. I should have said that before, but could you please respond to those, react to those questions?
Thank you so much, and greetings to Kun, and thank you, Kun, for the excellent and very important question, which really shows the depth of your work in the field. I want first to answer the first point, the inward-looking issue from agencies in the field and how it might affect negatively coordination. Good coordinators in the field can turn difficult situations like the ones you described into win-win situations for the beneficiaries. If you take these inward lookings and focus on agencies' niche, agencies' mandates, agencies' specialities, and target population, you can turn it into win-win situation by becoming as inclusive as possible and providing the highest quality for beneficiaries. If you have in your coordination meeting an agency which want to focus exclusively on the needs for women affected by gender-based violence. If you have an agency in your coordination meeting want to exclusively focus on needs for children, or focus on health aspects, or focus on protection, turns that into win-win situation by making every agency a focal point to link with other sectors and other clusters, and turn it into a win-win situation for beneficiaries. As much as possible, be inclusive in your coordination, and make sure you focus on agency niches and turn that into win for beneficiaries. Second question, how to engage with private sector during humanitarian emergencies. We have seen humanitarian emergencies where needs are huge, and you are in the field and there is a huge gap, and you have a resource, and this resource is accessible through private sector. I would say use this resource as long as it fulfills the following 3 criteria. First, do no harm principle. You need to make sure that this private sector is doing no harm for beneficiaries. For example, never collaborate, for example, with the tobacco industry, because clearly this would do harm for the beneficiaries and others. But first, apply the do no harm principle. Second, no conflict of interest. So do not collaborate with a private supplier of certain infrastructure while you're equipping, for example, an infrastructure for one of the MHPSS facilities. That's a clear conflict of interest. Avoid conflicts of interest. If there is a conflict of interest with one for-profit organization while you're buying equipments, you need clearly to declare that and avoid it. Third, apply the organization rules and the governmental rules in dealing with non-state actors, the legal aspects of it. If you apply these 3 rules, I think you can easily have a good collaboration with private sector, and again, turn it into win-win situation for the beneficiaries. Do no harm, no conflict of interest, and apply the legal rules within your organization or within the country. Thank you.
Thank you, Fahmi. And the question and also your answers reminded me of one of the priorities that we are, that one of the objectives that we set as the Netherlands for our own advocacy work, and that is that we really want to try also at the global level to involve, to engage more with private sector and private sector foundations, among others, using as an entry point the healthy workforce, and again, duty of care point of entry, is for which I think the COVID crisis, many, depending on the situation, of course, circumstances, but many people having to work from home and not being used to that has caused psychosocial needs to rise and to be more recognized. So that's something that we will work also at the global level in the coming periods. A set of questions and discussions, I think, has gone on in the chat, and it was touched upon a little bit earlier, and that is indeed on the question of the duration of the provision of short-term MHPSS expertise for coordination, and the duration of deployments. And I think that possibly Carmen would like to say something about that, if I'm correct. Please.
Yes, thank you so much, Renee, and thank you for the comments. It's been a very interesting discussion, and I think I would agree with every comment. Obviously, it always feels like too little to have 3 months, to especially in an interagency coordination kind of role, where you first need to spend quite some time in getting to know the stakeholders, etc. But I think it's important. Sandra unfortunately had to go to another commitment, but she's mentioned many times the importance of writing TORs that are very focused on working with the team already existing. If we aimed to deploy the colleague to provide coordination from scratches and create a technical working group and make it functional, that would be impossible in 3 months. The idea, what we really try, is to work with the country teams and to see through the TOR what could be the activities that this expert can help the most the existing team in revitalizing it and making it touching on the issues that might be more important. Sometimes it has to do with training and capacity building. Sometimes it's more of a humanitarian diplomacy issue that might be a little bit stuck, and the expert can have the expertise to unclog these issues. So I think I would agree that 3 months as such is not enough, but it really depends on what is it that you are aiming to do. And what we're trying to do is to be efficient with the resources that we have, so we can deploy more people by having shorter periods, but very dedicated to these specific useful activities. The other point that it has been echoed as well by Ibrahim, I think is very important to continue advocating for coordination being one essential role of technical working group teams. And unfortunately, that's not a position that is recognized and funded in itself. It's normally a colleague on the ground doing multiple roles, doing the projects of the agency that he or she belongs to, and being the technical working group coordinator. That's exhausting, and it would be ideal to continue to advocate with agencies to include this in their budgets and have a coordinator and fully fund that position so it can be more effective. And something I'm going to be cheeky and go to Maya, not so much from the point of the deployments, but from the point of revitalizing a technical working group. I think you have some interesting experience on how in a shorter period you can revitalize an existing structure.
Yes, thank you, Carmen. Yeah, I just wanted to share with my experience, really just going back to my point of, creating local ownership. Sometimes it's enough to go into a working group and reorganize and reinvigorate. In my particular experience, we had a discussion because we have a range of specialist MHPSS providers that attend the technical working group in Myanmar. We also have child protection actors, GBV. There's a whole range of issues. And I think that we weren't really addressing the needs of what people wanted to learn about, what they wanted to share. So we had one group discussion with a breakout session, and we marked down our top 10 interests that we're, for MHPSS, that we're interested in discussing. And this, was anything between suicide prevention, drug abuse, self-care, staff care, and we sent out, from this group discussion, we sent out a survey monkey to not only the MHPSS working group members, but also child protection and gender-based violence, and we had them mark and rate which topics were most important to them, and then we organized for the next year different specialized topics that we would cover for 1 hour of the 2-hour sessions, and we have a range of specialists that we were able to invite that were part of our working group that could present, that could share, and this really created the local ownership. It was actually quite easy to set this up, and at the point I was supporting the working group for this coordination, and it really started making itself every time we did these sessions. So I would just say, to come in and revitalize and to organize can sometimes be the key factor in creating that localization and ownership. So just wanted to share that perspective. Thank you.
Thank you so much. And it's good, this combination of a general and a specific elements of our experience, providing parts of the response. But of course, it's a discussion that needs to be held and continued because the search mechanism for the moment exists as it is. We're looking at how to continue it, and then of course you also have to include lessons to be learned. I think that most of the questions have been either, I hope, have been either answered through so verbally or in the chat already. I know there was a question about shelter and MHPSS, but I think that's been responded to in the chat. So, and I think also I have my little travel clock here, which was accompanying me. And I think it's indeed time to move towards already, you see it's going too fast, the closing part of this session. And for that, Fahmi, can I first of all give you the mic, let's say, and then I'll conclude after that.
Thank you so much for the great moderation and all the wonderful panelists today for sharing their experience. It's a great moment for mental health and psychosocial support, especially today at the ECOSOC, also with the Secretary General report on enhancing coordination in humanitarian settings, which has an MHPSS article, and also the member states resolution, which include a specific article on MHPSS. Great moment for MHPSS globally. Let me take this opportunity also to share reflections from what I heard today. Colleagues, let's just imagine the chaos of MHPSS in countries without MHPSS technical working groups. Imagine if MHPSS technical working groups does not exist. Imagine fragmented services, no referral, assessments repeated, trainings repeated, resources wasted, no learning, no sharing, no collective impact. I don't think we can have MHPSS really without MHPSS technical working groups, which are cross-cuttings. We heard today from colleagues examples for how functioning MHPSS technical working group coordination work in Nigeria, in Bangladesh, in Greece, in Myanmar, and in Yemen, and with good reflections on their day-to-day work through multisectoral collaboration within and across agencies. WHO always says there is no health without mental health. And today we can say there is no humanitarian response or coordination without mental health and psychosocial support and technical working groups. Key take-home message is that MHPSS integration is essential, should be cross-cutting, should be part of our assessments and programming. MHPSS is not a luxury, is not an add-on, but an essential component of humanitarian programming. There is still huge need and gap that exist in investing in MHPSS human resource and financial resources. Thank you, Renat, and back to you.
Thank you so much for a very clear couple of final remarks. And indeed, there's the title of the Netherlands conference, or the Netherlands hosted conference, was Mind the Mind Now. I would say mind the mind always. Maybe that would have been an even better title, but definitely don't push it ahead of you. Start minding it now. And yes, I wish to very much thank all the participants, the panelists, for your open and clear responses and your availability at quite a last moment. But especially for the work that you're actually doing and that you're sharing your experience on with us, and for your also patience with all those international discussions about resolutions and papers and things, because that sometimes seems very far away from the realities you're working on. But both are needed and both need to be connected, and that's why I very much value definitely your participation today. And a lot has been achieved over the past couple of years. Of course, a lot was done longer ago already, prepared, and then there came more political attention, and then we managed to really put this high on the agenda. And so there's that cascades down again into more attention. The Netherlands, we will continue to work on this and to try to advocate for this and to bring parties together. We are trying to broaden still further the support, the recognition and the support for integration of MHPSS in crisis response. We also try to ensure with many allies that it is firmly embedded, so that it doesn't go away if at some time after this pandemic, maybe the attention goes a little bit down, the political attention, but attention for MHPSS should remain. So we are very happy that MHPSS is now also really embedded in the ECOSOC resolution, and we'll work again hard to try to get it into the end of the year omnibus humanitarian resolution, because those are ways to not allow to slip away from the agenda again. We are also supporting facilitating implementation. Search mechanism is one example. The development of the minimum services package is definitely another example with WHO and other partners, because that should, once rolled out, should really help in any setting to actually integrate MHPSS into the responses. We're also trying to broaden the attention for MHPSS beyond the humanitarian sector, as I said before, working on getting the UN peace-building architecture more open and more structurally taking along mental health and psychosocial support, and also trying to integrate it in other fields of work in a more, again, a structural way and in a qualitative way. And of course, capacity remains really a big gap at the global level, and we're always trying to see ways in which we can multiply efforts that are ongoing to strengthen capacity or to increase capacity. And we think that with such kind of multiplier effects, we can also try to attract new financiers also to the field. So that's also something that we're working on. And of course, the ongoing lobby to get MHPSS mentioned in central policy documents, such as the recently renewed ECHO, the European Commission communication on emergency aid, which did not mention, which appeared not to be ready to mention MHPSS. It was not in a draft we had understood, so we pushed, and now it is mentioned in the actual communication, and that helps because then you can refer to it in your local lobby. Same, for example, with regards to the World Bank and the IDA replenishment. We really try to push to get it mentioned because mental health remains a stigma and a subject which is too easily thought of as difficult. So let's not also raise that one. This is the reason why we have to raise it. And if it's not in the global document, it will be more difficult to get it into national response plans and strategies. Also working towards the forthcoming next Global Mental Health Summit, which will be hosted by France and which will be focusing in October. It was planned to take place last year, but because of COVID, it was postponed to this year. And it will focus on the one hand on global health and global mental health and COVID, and on the other hand on mental health and human rights. And during that conference, there will be quite a long, robust session, one of the parallel sessions, but a session in which we will look back at what did countries and organizations commit to at the Amsterdam conference, the Amsterdam Summit, what recommendations were prepared, a whole set of very good and useful recommendations. Where do we stand on implementing those? And where do we need to improve our action? So definitely, I invite all of you to think along and to be well prepared for the French summit, because this work does not stop and beyond the French summit. And I hope that our work supports all of you and that your work has inspired a lot of the audience. And again, first of all, thanking the panelists, thanking the representatives of UNFPA, helping also in the technical organization of this panel, and thanking the co-organizers. And with that, 2 minutes ahead of time, how did I do that? That's bad planning on my side. But I thank you very much, and the recording will be shared with all the with everyone who's listening, who has registered for this event. I think it works like that. And with that, thank you very much. Have a good continuation of the day and of the week and of the work. And take care of yourselves as well. Thank you.
Thank you, Renate. Thanks, everyone.
Thank you
Bye-bye.
so much.
Thank you so much, Renate, for this time and the great time management, actually. And thanks to all the colleagues, Fahmi, Carmen, Deborah, we're not going to list, and those who are attending, actually. Thank you so much for your support and for being there. Thank you. Take care.
Thank you, Brahim. Thanks, everyone.
And panelists, thank you for keeping so well to the time. I didn't need to be strict at all. Thank you. Bye-bye.
Thank you so much,
Bye.
Renate. Bye, everyone. Thank you.
Bye.